Okay, so we will go ahead and start the next chapter, which is anxiety disorders. And here we go. We'll go ahead and talk about these. So we need to delineate between a couple of concepts to start out. We need to talk about anxiety, fear, and panic, just so we get everything straight here. So when we talk about anxiety, here we go. We're talking about a mood state that is negative in nature, in which there are symptoms of things like physical tension and apprehension about the future. Now, what's important about anxiety is that somebody is worried or concerned about something in the future. Not right now, something that is upcoming. Maybe it is an upcoming speech in class, or maybe there is a get together somebody's anxious about, but it's about the future. That's going to be important here. And then there's somatic or bodily symptoms, things like muscle tension, restlessness, elevated heart rate. Usually when there's anxiety, basically your central nervous system is going to be jacked up a little bit. On the other hand, this is going to be different than fear. Fear is about now, something that's happening right now. And this is definitely going to activate, again, that sympathetic nervous system and fight or flight, possibly. And here's, okay, I'll give you an example of the difference between these. So in regard to snakes, for example, if I'm talking about fear, because I am scared of snakes, if I'm talking about fear, and this is going to be right now, I am literally walking through my backyard and there is a snake in front of me. And I jump and run, which has actually happened. That is right now. Right now, I'm terrified. That is a snake. Now, on the other hand, in regard to anxiety, I may have anxiety about the fact that there could be snakes in my backyard. Now, I haven't gone out to my backyard yet, but I might, and I am anxious that if I go out and walk through my grass, there could be a snake. But again, it's future oriented. So that's where the differentiation comes into play. Also, both anxiety and fear, they are adaptive, they are protective, and like all emotions, they're useful in moderation. That's the key here, is that you don't want these to be activated at all times, because it basically blows out our central nervous system. You're in fight or flight constantly. Now, they become psychological disorders when they're out of proportion to the actual situations a person is encountering. Now, if we're talking about possibly like public speaking, that is a very common phobia, fear of a lot of people, and people are commonly anxious about talking in front of others. I actually am, believe it or not. And so the thing is it is normal to feel a little bit anxious. What anxiety does, it is enhances our motivation. It kind of jacks up your central nervous system a little bit and gets you going. But too much anxiety can be crippling and get in the way of you functioning, and you start to feel again like you're having a heart attack, you can't breathe. That's when it becomes pathological in nature. Okay, so as I was talking about here, yes, fear, jumping out of the way if I see a snake. Anxiety, again, worrying about a snake if I go on a hike or in my backyard. And again, with both anxiety and fear, they're negative. Sorry, I'm trying to find my anxiety disorders for you here. There we go. Both of them have a negative affect, which means there's going to be negative symptoms associated with these feelings. They don't feel very good commonly. Okay, so these are some of we won't go through all of these disorders. We'll go through enough that you get a basic understanding of the disorders related to anxiety, but we have generalized anxiety disorder. That's going to be the most common one that people come across. Panic disorder and agoraphobia, specific phobia, social anxiety disorder, separation anxiety disorder, and selective mutism. So we'll cover a couple of these, but not all. Okay, so first and foremost, we'll talk about a panic attack. This is going to be a little different than panic disorder, but we need to first go over a panic attack in order to understand panic disorder. So a panic attack is when there's an abrupt experience of intense fear. Now, I'll also offer my, in the DSM-5 text revision, you might find it under panic attack specifier. That is an isolated panic attack. And I'll give you some examples because I have had panic attacks in the past. They're very much under control at this time, but I would say it's beyond intense fear. It's an incoming sense of dread or death is the way that I would explain it. So intense fear may not be enough to completely explain a panic attack. Some of, let me make sure I got this. Yes. Okay. Some of the physical symptoms: heart palpitations, chest pain, dizziness, sweating, chills, or heat sensations. When I've had my physical symptoms of when I have a panic attack. And again, I'm hoping that this can just help people relate. I've had people in the past where they've had these symptoms and gone through this, but they didn't know it was a panic attack. So I'm hoping that it humanizes this a little bit for people, but it feels as if your heart can't stop racing. Your chest is like closing in on itself. It feels extraordinarily tight. With dizziness. I've never been able to have a panic attack standing up, I'll tell you that. Sweating, when I've had my panic attacks, is that it's as if it's basically like you're drenched and it's just flowing off of you in it's just pouring off of you. Chills and heat sensations. Yes, I've had them go back and forth and back and forth. You're freezing, then you're hot. You're freezing, then you're hot. Shaking as well. Nausea, that's been there as well. Feeling like you can't breathe, like you're going to hyperventilate. And then also there's cognitive symptoms. You feel like you're losing control, dying, or going crazy. It feels as if the world is closing in on you. Yes, or that you're having a heart attack, that you're dying, that you're sure that this is death. And when it comes to panic attacks, and again, they can come on suddenly, and we're going to talk about expected and unexpected panic attacks, but they typically reach a peak within 10 minutes. And they're accompanied by uncomfortable physical sensations and catastrophic thoughts, like we've been discussing here. And so, yes, two types: expected, and this is when they're cued by some sort of situation that is very specific. So if you know, like, okay, I'm going on next to publicly speak, and I know I have a panic attack. Oh, there I had my panic attack. Or where you've had them in the past. Maybe there's a certain intersection where you got in a car accident at one point, and every time you go to that intersection, you have a panic attack, and you probably avoid it now because of it. But that would be an expected one. You know that is going to happen if you put yourself in this situation, or it's likely to happen. Unexpected, they just happen out of the blue. I've had unexpected panic attacks for quite a bit of my life until recently, and they would just happen out of nowhere. I might be in a stressful situation in which I've had them. I've also had them when I'm just sitting on the couch doing nothing and completely content and calm, just completely out of nowhere. So this is the panic attack specifier. Again, so if you are somebody that has panic attacks and they are unexpected, you would be diagnosed with a panic attack specifier, possibly tacked on to an anxiety disorder. So when it's a specifier with any of these, I mean, there's specifiers throughout this text, but we don't go over many of them. When it's a specifier, it's very commonly tacked on to another disorder. So it'd be like generalized anxiety disorder with a panic attack specifier. So that's how they would link. But nonetheless, these are the symptoms you would need in order to be diagnosed with the panic attack specifier, probably attached to an anxiety disorder. And yes, it's not considered a psychological disorder in and of itself. It's just when it happens in the context of another psychological disorder, again, probably anxiety, and needs to be included as a specifier. So what you have to have an abrupt surge of intense fear or discomfort that reaches a peak within minutes, again, up to about 10 minutes, and during which time you have at least 4 or more of the following symptoms. So again, you can mix and match to your heart's content with these, but you'll just need 4. Heart palpitations, a pounding heart, accelerated heart rate, sweating, trembling or shaking, feeling like you're choking, chest pain or discomfort, nausea, abdominal distress, dizziness, being unsteady on your feet, lightheaded or faint, chills or heat sensations. And then we have what's called paresthesias. And this is when you have the tickling or pringling. It's like pins and needles in your extremities. So it's kind of like when you're, let's say your leg goes to sleep because you haven't moved it in a long time. And then you start to get feeling again. It's those prickly feelings. Also, derealization. We just talked about this, where you feel detached from your surroundings. Again, people and objects around you may seem unreal. So again, maybe they're blurry, maybe they're in 2 dimensions, maybe time is slowing down. fear of losing control or going crazy, and fear of dying. 4 of those, you would have the requisite symptoms in order to add the panic attack specifier, probably to an anxiety disorder. If you are somebody that's having a panic attacks, and again, they're not expected, but you're having panic attacks, you probably have an anxiety disorder along with it. Or another disorder that I'm just not thinking of right now, but anxiety is very common. So we have that panic attack specifier that can be added on to any psychological disorder, but then we have panic disorder. And so this is when you have reoccurring unexpected panic attacks. Now, here's the difference between just a panic attack specifier and panic disorder is that, and here's where I have only been giving the specifier because I'm not really, for whatever reason, even though I have high levels of anxiety, I'm not really worried about my next panic attack. I worry about everything else on this planet, but I'm not really concerned about the next one for whatever reason. That's different than somebody with panic disorder. This is when, again, they're having unexpected panic attacks pretty regularly, or they occur over and over, and you have at least one attack that has been followed by 1 month or more of both, or of one or both of the following. So things like persistent concern or worry about other panic attacks or the consequences of panic attacks. So once you have a panic attack, you're worried about the next one. When is the next one going to occur? Is it going to happen while I'm driving? Is it going to happen while I'm in class? Or the consequences of panic attacks, are people going to laugh at me? Am I gonna, fall off the stage? Am I gonna pass out? That kind of worry about the panic attack does show, again, that concern and would upgrade a panic attack specifier to panic disorder. And then also a significant maladaptive change in behavior related to the attack. So if maybe you had a panic attack while you were public speaking, and an example of a maladaptive change in behavior would be that you dropped out of public speaking if you were in a public speaking class, or you made sure that you did not speak in a group anymore. Maybe you avoided groups, you avoided any sort of situation in which you had to have interaction with, more than just a couple people, because again, speaking in front of people or around a crowd causes those panic attacks. And so you avoid it at all costs. Or you have panic attack while you're driving, you stop driving. That would be another example of that. And it's not attributable to substance use. Yes, stimulants can cause panic attack related symptoms, and it's not better explained by another mental disorder. So again, that's the difference between the panic attack specifier and the disorder, is that you have, for the disorder, you have reoccurring unexpected panic attacks that you're worried about, or you're worried about what might come of it, or you're changing your behavior in a maladaptive way because of the panic attacks. Okay, so some theories about panic disorder. There are some biological factors in that there is a heritability rate of 43 to 48%. So that doesn't mean that, like, if you have a parent that has panic attacks or panic disorder, that you almost have a coin flip chance of developing panic disorder. What it means is that when we talk about heritability, that is the chance that you receive a gene for that predisposes you to panic disorder, or the symptoms related to panic disorder, so to speak. And so again, you have about to have a coin flip chance. Let's say both of your parents have panic disorder. You have a coin flip chance of receiving a gene that predisposes you to this disorder. But then we also have to take into consideration the environment, because you don't come out of the womb with a panic attack. At some point in your life, you probably start to have them. And so it has nothing to do, or it doesn't just have to do with the gene you receive, it has to do with the environment that you're in. Are there stressors that first caused that first panic attack, or caused enough stress that it changed the expression of that gene, thus resulting in a panic attack? Some people are triggered into panic attacks in a variety of ways, like if they hyperventilate or inhale some carbon dioxide. This is kind of backwards, but some people can have a panic attack when they breathe into a paper bag, even though we think of, oh, you're hyperventilating or having an anxiety, breathe into a paper bag. But nonetheless, this is part of the literature. Also, ingesting caffeine or taking infusions of sodium lactate, you're going to jack up your nervous system, potentially causing a panic attack. Also, people show dysregulation of norepinephrine systems in the locus coeruleus, which is basically the base of the brainstem, which is going to be attached to, you're looking at the hippocampus, the hypothalamus, the amygdala, all of that in there. There's a pathway here. So you're looking at basically dysregulation at part of your brainstem. And the norepinephrine system, norepinephrine is going to be a excitatory neurotransmitter. And so again, if that is not working correctly, that can overexcite or overstimulate other parts of the brain, thus causing a panic attack. Okay, so those are just some biological factors. In regard to cognitive factors, okay, so we're talking about thought processes or some of the more complex thought processes, but people prone to panic attacks, they tend to, okay, these are people who pay very close attention to bodily sensation and misinterpret them in a negative way. So this could be somebody that, you know, maybe they're having a pain in their side. And again, it's not because I maybe slept wrong, it's because I have a tumor. Again, they're paying too much attention to the things going on in their body, and they're misinterpreting them in a negative way, kind of leading to a panic attack. They engage in catastrophic thinking, exaggerating symptoms and their consequences. So literally, this could be, you know, I did have a headache today, and I don't get headaches that often, so it must be brain cancer, and I'm going to die. That would be an example of catastrophic thinking. Being sensitive to anxiety, yes, the unfounded belief that bodily symptoms have harmful consequences. And so just because, you know, I'm having a stomach ache or a headache, or, you know, maybe I am a little bit more anxious than usual, there's going to be negative consequences to that. So you move quickly to anxiety. Your body does not necessarily, or your brain and body do not process anxiety well. There's some dysregulation there. And so it's easy for you to fall into anxiety more than others. Also, interoceptive awareness. So you have a heightened awareness of bodily cues that signal a coming panic attack. So maybe when you have, again, interoceptive means being aware of what's going on inside of you. And so this could be, again, your heart rate is raising a little bit. And so as a result of that, you'd think, oh my gosh, a panic attack is happening. Or maybe you get a little bit of a tremor in your hand or something like that, or your stomach starts to hurt, or maybe you sweat a little bit. And because of that, that can actually induce a panic attack. So it's kind of a self-fulfilling prophecy. Also, interoceptive conditioning. These bodily cues that occur at the beginning of previous panic attacks become conditioned stimuli signaling new panic attacks. So maybe when you had your first panic attack, you just started sweating, just profusely sweating. You're like, what's happening? And you had a panic attack. And so what happens there is what we call, again, classical conditioning, in that you started to attach those two things, that if you sweat, that's going to result in a panic attack. And that's actually what happens. When you sweat profusely, that can actually induce a panic attack. So just these things that are happening in our brain can actually result in panic attacks on their own. Okay, so there are medications. When it comes to any of the anxiety disorders, unless they're utterly extreme, I usually say that the research indicates that cognitive behavioral therapy and a couple other approaches are going to be the most effective long-term approaches to anxiety disorders. When we talk about the medications for anxiety disorders, they're not cure-alls. They just aren't. What they are Band-Aids. They are Band-Aids, and so when you take them, they're literally just masking the symptoms until you stop. And with some of these, they're actually, if we talk about benzos, they're physically addictive. And so you're putting yourself at risk for addiction with these. And this is kind of an easier way to manage these things. But again, if you're talking about like your classical benzodiazepines, they lose their efficacy really quickly, and so as a result of that, you need to up your dosage, and then again, you do develop that physical tolerance to them, and it can be difficult to get off of them. And again, like it says here, there's a high relapse rate after you stop taking the medication, which means that most people will fall back into the anxiety they originally experienced because they did not do the requisite cognitive treatment that would actually help them more. So there's a couple different systems that could be affected by medication. The serotonin, noradrenaline, and gamma aminobutyric acid, like we've talked about. And kind of trying to level these off, basically trying to enhance GABA drop the noradrenaline, and increase serotonin. Again, what that's going to result in is in a slower nervous system that's more relaxed and content, allegedly. It's not out of the realm of possibilities that a clinician will put somebody on an SSRI. Again, those are your traditional antidepressants. This could be like Prozac, Paxil, Zoloft. Those have been used, Wellbutrin, those have been used to treat anxiety. And in some people it works. Most stereotypically though, if it's purely an anxiety issue or a higher level anxiety issue, benzodiazepines are what are commonly used. So again, these are addictive, and they include the drugs like Ativan, Klonopin, and Xanax. So I'm sure at least one of those rang a bell. And they are addictive. And again, when somebody's on a benzodiazepine, it should be like a month at most, maybe 2 if we're pushing it. But that's about it. It should be used in such a way that it allows somebody to get to therapy and do the work and then wean oneself off of it. Long-term use is usually not recommended. So there's also psychological interventions, like we're talking about, exposure-based. So in consideration of this exposure-based treatment, what they're talking about is that whatever you're anxious about, they slowly introduce you to it. So, maybe this could be somebody that's agoraphobic, they're afraid to go outside. I mean, maybe where you would start is maybe you would start with them possibly looking at a picture of the outside. Then maybe we're looking out a window. Then maybe we're looking out the window by the door. Then maybe we open the door. Then maybe we go and stand out on the stoop. Now, I'm saying those things, and every single one of those steps, it could take weeks, months. And so we're talking about taking baby steps to overcome that anxiety. Also, kind of doing reality testing, and this would be done in your cognitive behavioral therapy, but testing, again, the individual's hypothesis that they can't handle an anxiety-producing situation by actually entering the situation and discovering that it is survivable. So again, maybe they're agoraphobic and they don't like to be around crowds. And so somehow you get them to go to Walmart and you go down the ice cream aisle. And basically what you're doing is trying to get them to recognize, like, hey, we're still alive. You did it. That's reality testing. Being able to get them to realize that, no, you will survive it. You will make it through. And look, you did it. Also, relaxation and breathing skills. So doing like full body relaxation or deep breathing can aid in bringing, again, that central nervous system down. Also, panic control treatment, that's PCT, being exposed to interoceptive cues. So again, what's going on inside one's body and understanding, like, okay, that doesn't mean it's going to result in a panic attack. Cognitive therapy, and again, relaxation and breathing. These have high degrees of efficacy. These are highly effective, is what we mean here. In comparison to, and I think I have a table on the next page to show that this is much more effective than just medication. The combined psychological and drug treatments. So if you combine both psychological and drug treatments, it's not better than CBT or drugs alone. The best long-term are one of these therapies. That is going to be the best long-term treatment for somebody's anxiety. Otherwise, you are merely masking the issue. Even if you add medication to a therapy, there are not better outcomes overall or on average than if you just would do the therapy. Okay, so now that we got through panic attacks, and again, pretty much all of that goes for most of these anxiety disorders. The treatment is the same for the most part, to a certain degree. The medication is the same. And so a lot of what we just talked about can be applied across the board. So we have what's called separation anxiety disorder. So this is when, oh boy, I don't know where this is. That's social anxiety disorder, phobias. There we go. Okay, so this is when an individual has developmentally inappropriate and excessive fear or anxiety concerning separation from those to the individuals attached. Okay, so when I say developmentally inappropriate, I mean if you have like a 2-year-old that is throwing a fit because mom left the room or went to the store, yeah, that's developmentally appropriate. It's a 2-year-old. But if you are 16 or somebody's 16 and that is happening, there's probably an issue that is developmentally inappropriate. And again, there's an excessive fear because you are separated from that person. And again, for somebody whom the individual is attached, it could be a parent, it could be a sibling, it could be a significant other, it could be a child. And you have to have at least 3 of the following. Okay, so we could be talking about in children, we could be talking about in adults as well. So across the lifespan, you can be diagnosed with this. So there is excessive distress recurringly. So there's consistent excessive distress when you anticipate or experience separation from home or major attachment figures. So again, maybe this is a parent, sibling, significant other, or it's just being away from your home. Persistent and excessive worry about losing major attachment figures or about possible harm to them, illness, injury, disasters, or death. So this is when they literally, like, you're terrified of somebody you love getting on a plane, like you think they're going to die, or they go on a trip, they're going to die, but something horrible is going to happen to them. You are worrying about it every day, all day, basically. And don't get me wrong, we all worry about bad things happening to family members, but it probably doesn't encompass our entire being. Persistent and excessive worry about experiencing an untoward event. So like getting lost or kidnapped that causes separation from a major attachment figure. And so, I mean, this could be with a parent, it could be with a significant other, something like that, but something that is going to cause you to be separated from them. Just some weird situation, literally like kidnapping, getting lost. It's just something that's outside of the norm that most people really don't consider. That's going to separate you from that person. The reluctance or refusal to go out, away from home, to school, to work, or elsewhere because of fear of separation. So you want to stay home because that is where your person is or your parents are. Like you won't go to school, you won't go to work, or you don't want to. Persistent and excessive fear or reluctance about being alone or without these attachment figures at home or in other settings. So you don't like to go anywhere without them. And you don't even like being at home alone without them. Persistent reluctance or refusal to sleep away from home or go to sleep without being near a major attachment figure. So even with, I mean, going somewhere else and staying in a hotel room, that's not really something that somebody with this would do, especially if their significant other or person, so to speak, is at home. Or if that person is out of the house, like you don't want to go to sleep because that person is not there. Nightmares involving the theme of separation, yes, because your brain is thinking about it all the time, so it's going to manifest itself in dreams. And also complaints of physical symptoms, headaches, stomach aches, nausea when separation from major attachment figures occurs or is anticipated. So if you think that person is going to be away for a while, or they are, these physical symptoms are usually those symptoms can be related to anxiety, especially with kids. Those are very common symptoms that kids will report. But in fact, it's anxiety. But they don't necessarily know how to express that at that point. And instead, they know how to express like physical feelings. But it's truly anxiety underneath. Okay, so with this, okay, so we got B now. So you have at least 3 of those. Then we've got B. And the fear, anxiety, or avoidance, it is persistent, lasting at least 4 weeks in kids and 6 months or more in adults. So all you need is a month for kids and you need 6 months for adults. And it has to be pretty persistent. It has to happen most days for most of the day. Most of the day for most days during this period of time. That's what persistence is. And this disturbance causes clinically significant distress. Okay, so it is going to be distressing because being away from that attachment figure is going to cause anxiety, fear, sadness, depression, all of those type of feelings, probably chest pain, shaking, trembling, sweating. you name the type of distress, and then impairment in social, academic, occupational, or other important areas of functioning. Yes, so again, we got 3Ds. The deviance piece is already there in that this behavior is outside of what we expect socially at a certain developmental age. But then this is going to get in the way of you being able to function in society because you have a hard time leaving or being away from a specific person. And it's not better explained by another mental disorder. Oh, I did not give you the statistics for the panic attack and panic disorder. I might go back here. Okay, so in regard to separation anxiety, before I move backwards, the 6 to 12 month prevalence of this in kids, it's right around 4%. So it's about 1 in 25 kids will be could be diagnosed with this. And in, let's see here, in community sample toddlers, this appears to be basically 50-50 among girls and boys. But once we get to school age kids, girls appear to have higher prevalence rates than boys. In adolescents in the US, the chance of a kid developing this disorder is 1.6%. So 1 or 2 out of 100. And it does decrease as kids get older and they move into adulthood. Okay, and for adults, the 12-month prevalence rate in the United States is anywhere from 0.9 to 1.9. So somewhere from 1 to 2 out of 100 again. Women tend to have higher prevalence rates. Across 18 countries, the average 12-month prevalence rate, again, the chance you might develop it in the next 12 months in adults is 1%. Higher prevalence rate was observed in women compared with men in this sample. So 1.3 compared to 0.8%. Okay, so that is our separation anxiety. Let's talk about the etiology of it just for a few minutes. But again, your psychological vulnerability and environment. All right, we're doing well. The belief that threatening events are uncontrollable. And so as a result of that, you're basically attached to this person. It develops after life stress, especially a loss, like a pet, divorce, change in school, immigration, again, because you're scared of losing more. Being bullied is shown to be a risk factor. Parental overprotection, so some of your helicopter parents, again, because again, the kid hasn't been given the chance to be independent and create distance. And so this is what they expect. A generalized biological vulnerability, again, so your propensity toward anxiety, like we were talking about, are you just somebody who's more sensitive to anxiety in general? And just like we're prepared to fear dangerous animals like snakes, bears, whatever you want to say, we're prepared to fear angry or rejecting people. So it is evolutionarily useful to worry about social rejection because we're more likely to survive if we are socially accepted. And so as a result of that, again, we attach to others because they accept us. And we stay away from those we perceive to reject us. And it does have a 73% heritability rate, which means, again, it does not mean you have a 73% chance of getting it if you have a parent that has it. What it means is that you have a 73% chance of receiving it from a parent who has the genetic propensity to it. But again, just because you receive the gene for it, again, it depends on whether, you know, your mother or father passes it down and you get it. If you receive it, you have a 73% chance of developing this. And that is pretty high. It is pretty high. But what it also indicates is that there's probably just anxiety disorders running through your family. But then again, you have to be in a situation in which there's enough trauma or triggers or stressors that turn that gene on, so to speak. Okay, some treatments, again, well, we talked about cognitive behavioral therapies, teaching skills like coping and challenging cognitions that feed anxiety, like, oh my gosh, if I'm away from this person, they're gonna die. Learning relaxation exercises, challenging fears about separation, and use self-talk to calm themselves, like it's gonna be okay, it's gonna be okay, it's gonna be okay. So there are some medications. We have beta blockers. Again, this is going to lower blood pressure and overall, again, heart rate, things like that. Benzos and SSRIs, like we also talked about. Those will be commonly used. Again, so it's going to be pretty similar across the board. Now, just moving back a little bit to panic disorder, and I'm really sorry that I went ahead without telling you guys this, but when it comes to the prevalence, it's a little bit higher. The chance of developing panic disorder in the next 12 months is right around 2 to 3%, which is a little higher than some of the other disorders we've talked about. The lifetime prevalence rate, okay, and so it's at 1.7%. Or sometimes somewhere between basically 2 to 3% again. So over the entirety of your life, you have a 2 to 3% chance of developing panic disorder. Let me see if there's women are more frequently affected by men, about a 2-to-1 ratio. There was one. There is a higher rate of suicidal behavior amongst those who do have panic disorder. Let's see here, approximately 25% of, again, individuals who are inpatient with panic disorder report suicidal thoughts. And it does increase the risk for future suicidal behaviors, but not deaths necessarily. So, that's compared to some of the other things we talk about, it's a little bit more positive, but still pretty negative and difficult to deal with. Okay, so we just talked about panic disorder. We talked about separation, anxiety disorder. Now we need to talk about generalized anxiety disorder. If you were ever to be diagnosed with any anxiety disorder, it's probably going to be generalized anxiety disorder. It's the most commonly diagnosed, probably one of the most commonly diagnosed disorders in this entire book. Okay, so some of the aspects that you will commonly see in somebody who has generalized anxiety disorder. They shift from possible crisis to crisis. They worry about minor everyday events, job, family, chores, appointments. It's accompanied by symptoms like sleep disturbances or irritability and lead to behaviors like procrastination and over preparation. Okay, so for example, with mine, and again, for some reason I can do certain things and other things I don't do as well, but I do have I do have intense anxiety about making phone calls. God forbid anybody call me. It will take me a while to get back because I basically have a phobia. And in regard to shifting from possible crisis to crisis, I mean, I might make a phone call to somebody once every Monday to check in with them. Okay. Once I get through Monday, I'm okay for a little bit. But then I shift knowing like, oh, I have to make this phone call again next Monday. And the next, and the next, and the next. So it never ends. And again, something like a phone call is really not, it is very much outside the norm of something that is expected to be worried about. It is a minor everyday event that most people do pretty regularly and functionally. I do not. And yes, it is accompanied by symptoms like sleep disturbances, irritability. Yes, on that Monday before I make that call, on that Sunday, I start to get very anxious. I don't sleep as well Sunday night. I'm not as easy to get along with on Mondays. Tuesdays, I'm great because that phone call's been done. I have a week until the next one comes around. And let's say that I get a phone call from like a doctor or something like that, and they need me to call me back to get some results. You might hear from me in a week or 2 weeks. Maybe. I'm going to procrastinate every phone call as much as possible. And for that Monday phone call, I'm going to prepare. I'm going to possibly prepare like, okay, I'm going to basically, that is all I'm going to do that day. I'll go to work and then this is all I'll focus on in the afternoon, thus leading to nothing else being done because I just can focus on this. I am over prepared for it. So, and again, this can be about anything for anybody. I'm giving you a look inside of my brain a little bit because it doesn't have to make sense. When you have anxiety, again, it's usually about things that are outside of what is normal. If it's anxiety about something that is normal, then it's not really considered to be pathological anxiety. It's just normal anxiety. But when it's about something that's abnormal, that's when we get into the pathological part. Okay, so here's the criteria that you'll need in order to be diagnosed with an anxiety or generalized anxiety disorder. First one, you got to have A, excessive anxiety and worry occurring more days than not for at least 6 months about several events or activities. Okay, mine is phone calls. Also, I really don't do well like going to the store or going to drop off a package at the post office. Again, for whatever reason, or social events. again, I have intense anxiety about all of those things, um, pretty much all the time. And again, so we got several events. These are things that I've been anxious about for about 30 years now. There, I'm aging myself for you. And the individual finds it difficult to control the worry. Yes, when you're experiencing this, you can do whatever it is that you can to try to bring yourself down, but it doesn't work. It doesn't feel like you can bring the temperature down. And your anxiety and worry are associated with at least three of the following: restlessness or feeling keyed up on edge. Yeah, so you're jacked up. You're tired. You have a hard time focusing. You're more irritable than usual. That muscle tension, and you don't sleep as well. Maybe you'll have all of them, who knows? But again, you got to have three of them in consideration of those several events or activities. And they cause clinically significant distress or impairment in social, occupational, or other areas of functioning. So, I mean, again, the phone call thing that I'm talking about, that is outside of what is normal. It does cause dysfunction in that I really don't get back to people very well, and I try to stay away from my phone, which isn't great because I'm not in communication with people as well as I should. And it is distressing because I'm always worried that somebody's going to call, and then I'll have to call them back. Like I'm under constant anxiety about that. There's the distress. And you have to make sure the disturbance is not attributable to another substance or medical condition or another mental disorder. So, some theories of this: biological factors. And just so we're clear about this, I'm almost positive anxiety runs through my genes for many generations. So I probably have the propensity for it, but then triggers along the way helped bring it out. So some biological factors: they may have, people with this disorder may have lower levels of gamma aminobutyric acid. That's GABA. That's one of our inhibitory neurotransmitters that if there is not enough of it, there's too much stimulation in the brain, and thus again, you're keyed up a lot. It leads to excessive firing in neurons in many of the brain, and you have chronic diffuse symptoms of anxiety. So again, you just can't slow everything down. And again, there's a modest heritability rate of 33%. So again, it's mildly heritable. You got a 1 in 3 chance of receiving the gene if your parents have it, but then you have to talk about it being expressed. So it's a lot lower than separation anxiety, which we just talked about. Okay, the most common treatments: cognitive behavioral treatments, confronting most common worries. So it'd be like sitting me down and making me make phone calls or talk to a telemarketer or something. Challenging catastrophic thoughts. Again, like with this, what do I really think is going to happen if I talk on the phone or take a phone call? Is the phone going to blow up? Is somebody going to judge me? The therapist's job would be to talk about that and say, you know, do you really think that if you're talking to somebody on the phone, they're going to judge how you think or how you talk or how long you talk? And again, the answer is probably no. And so it's trying to, again, talk through that to make somebody recognize like, that is a little bit blown out of proportion, and trying to get around that, and developing coping strategies. And so in regard to that Monday phone call I make, you know, the night before, deep breathing, relaxation, things like that. Maybe, you know, going for an extra walk, something to clear my mind or distract myself. And then the same thing working into Monday, kind of keep my Mondays a little bit light so there's not extra stress added on. Some biological treatment, we talked about those benzos, Ativan, Klonopin, and Xanax, and also some tricyclic antidepressants and SSRIs can also be helpful. I mean, I've seen everything from like Celexa to Prozac to Zoloft to Effexor used for generalized anxiety disorder. With something like Effexor, which is actually an SNRI, it works on anxiety in very high doses. So if you can get up to that 225, 300 milligram level, it will work on the depression prior to that. But if you get to those higher doses, then it starts to work on the anxiety. So depending upon the medication you're talking about, it might require different dosing. Okay, so we've got generalized anxiety disorder, but then we have social anxiety disorder. So with social anxiety disorder, you have a marked fear or anxiety about one or more social situations in which you are exposed to possible scrutiny by others. So this is literally when you're worried about somebody judging you. Examples include social interactions and performing in front of others. Again, talking in front, like doing a public speech. You're worried that people are going to judge you, throw, tomatoes at you. Somebody's, you have a hard time going to some sort of social event because you don't know how other people are going to react to you, or again, think about you. Okay. Okay, so we have that. You have to have that. Let's see if there's something else. Oh yeah, having a conversation, meeting strangers, eating or drinking. Okay, so like being observed. This might be people who refuse to eat or drink in public, and performing in front of others. Yes, giving a speech. And the individual fears that they'll act in a way or show anxiety symptoms that will be negatively evaluated. So again, you're going to be humiliated. You're going to be embarrassed. Something's going to fall out of your mouth. And again, it's either going to offend others, you're going to be rejected by others, something of the sort. And the social situation almost always provokes fear or anxiety. Like it's not just once in a while, it's pretty much all the time. Like 99% of the time, you are going to be worried about going and doing this. You're going to be worried about going and having lunch with somebody. You're going to be worried about going and having and spending time with your friends, or going and speaking in front of a group. And it's out of proportion to the actual threat posed by the social situation. Speaking in public is not going to kill you, but it feels like it is. And that's truly what matters. So again, yes, logically, no, it's not going to kill you. Is making a phone call going to kill me? No. But does it feel like it? Yes. Your anxiety gets high enough that, yeah, it is going to cause immense amounts of damage. And it's persistent, typically lasting 6 months or more. So again, it has to be for an extended period of time, most days for most of the time during the day, in order to get this diagnosis. Oh boy, the fear, anxiety, or avoidance causes, again, clinically significant stress, impairment in social, occupational, and other important areas of functioning. Again, as you can see, we see this in every diagnosis. It's not attributable to the effects of a substance. And it's not better explained by another mental disorder. Also, we have a specifier. Again, I'm talking about a lot of specifiers today. You can also do a performance only social anxiety disorder, and that's when the fear is just about performing in public. So again, it's public speaking, getting up on a stage, something like that. You would be able to specify that. So some theories of this genetic basis, yeah, it does run in families. First degree relatives have a 2 to 6 times greater chance of having social anxiety disorder. That can also be not only genetic, but it could also be because of the environment that they live in. And that, again, through modeling and conditioning, that kids kind of learn similar behaviors to their parents, thus resulting in this. And it tends to lead to a greater general tendency toward anxiety disorders as well. Yes, if you have that genetic basis. The cognitive perspective is that individuals with this have excessively high standards for their social performance. So they believe that, like, if they say one wrong thing, they're going to lose all their friends. Or if they screw up one word on stage, like the world is going to end. So again, they're perfectionists. And they focus on the negative aspects of social interactions and evaluate their own behavior harshly. So in most cases, like, even if like you slip up on a speech or you say something dumb in front of your friends, in general, they never think about it again. You might think that they think about it, but in all reality, most people don't think about us as much as we think. They're probably thinking about themselves. But again, it's very common for us to be like, oh my God, they're never going to forget what I said there. It's so embarrassing, blah, blah. No, they already forgot. And again, I'm saying that logically, but again, for anybody with any of these anxiety disorders, it's easier said than done. So some treatments, yes, we have the SSRIs and SNRIs. You could throw in benzos too if you wanted to. But again, that cognitive behavioral therapy is going to be very helpful. So identifying negative cognitions people have and learning how to dispute these cognitions. So again, if I say something stupid, my friends are going to hate me. So again, the therapist is going to confront those negative cognitions. Or like, oh, if I screw up one word, like they're never going to let me do a speech again. I'm never going to not feel humiliated in front of those people. Again, identifying those and talking them through, possibly over and over and over. Also, mindfulness-based interventions. So basically accepting anxiety as it is, like it's there. And observing it rather than judging it, rather than being like, oh my gosh, I can't believe I'm anxious again and it's getting worse and I hate it. It's just there. And letting it be. And instead of judging yourself, avoiding people or situations, just letting it be. That this is part of how your brain works and it just is. So just kind of accepting it. Also, literally things like meditation, other mindfulness-based practices are also helpful in regard to social anxiety disorder. Now, this is what we were talking about. Oh, wait, hold on. Oh, social anxiety disorder continued. So, okay, this is kind of what we've been talking about to a certain degree in that, okay, so this is the level of social phobia or social anxiety that somebody was dealing with. And let's say, again, everybody started way up here, okay, before anything. All right, so, okay, purple, these are individuals that had CBT. Again, this cognitive therapy that we've been talking about, you can see how low their social anxiety got by the 12-month follow-up. Okay, then you had, okay, so again, you just had somebody that went through cognitive therapy. Great. Then you had the placebo, which is, again, nothing. They probably took a sugar pill plus self-exposure. So again, trying to put themselves in a situation that makes them anxious. Didn't go very far. It went down a little bit, but not that much. So your placebo not working. Then you have somebody who's using Prozac. So again, we're looking at the medications plus self-exposure. Again, does not meet up with as much as cognitive therapy does. Again, what this shows is that cognitive therapy is going to be much more effective than your self-exposure. Is going to be much more effective than any medication they can give you. You can see that by this. And this is pretty standard. This is replicated all across the board. All right, so then we have specific phobias. And when it comes to specific phobias, and I don't know if we go through agoraphobia on its own. You can lump agoraphobia in here because it's basically the same diagnostic criteria, but just a different context. So with specific phobias, now, you have to have a marked fear or anxiety about a specific object or situation. So things like flying, heights, animals, getting an injection, seeing blood, let's see here, airplanes, elevators, enclosed spaces, choking, vomiting, loud sounds, clowns, getting medical care, snakes, trying to think of other ones. There's plenty here. We'll go through a few more, but that kind of gives you an idea of basic ones, but it can be anything. You can be phobic of anything. So again, it's immense fear. And it almost always provokes immediate fear or anxiety. So every single time that somebody like sees blood, they just can't handle it. They're absolutely terrified. Or every time they see a clown or they get on a plane. And in some cases, they won't get on the plane. And it's out of proportion to the actual danger posed by the specific object or situation and to the sociocultural context. So in regard to like clowns, in general, unless it's John Wayne Gacy, you're probably good. You're probably good. Clown is not going to hurt you. But again, you can't tell that to somebody with a phobia because they literally feel as they're literally terrified. Whether it makes logical sense to the rest of the world, it doesn't matter. It doesn't matter. Again, I was talking about my phone situation. Yes, probably generalized anxiety disorder, but a little bit of a phobia too. Because it always provokes immediate fear or anxiety, like clowns or flying. And when somebody has to be exposed to their phobia, they either avoid it or they endure it with intense fear or anxiety. So either, like we'll talk about flying, maybe they never fly. They demand to drive. They will not fly across the country, they will drive. Or it's endured with intense fear or anxiety. So maybe in order to cope with it, they get some medications, they drink heavily beforehand, but they are dealing with it with intense fear or anxiety. And the fear or anxiety, yes, it's out of proportion to the actual danger, like we were just talking about. It's persistent, typically lasting for 6 months or more. So again, it has to happen over an extended period of time. And it causes clinically significant stress or impairment in social, occupational, or other important areas of functioning. If you have to fly for work or for anything in general and you can't fly, that's going to be difficult. If you work in a hospital and you have a phobia of seeing blood, you're going to be in trouble. And again, it's going to cause you distress. You are going to be terrified. You're going to be terrified. You're going to want to get out of there, get away from it, whatever it might be, not do it. And it is deviant as well. And again, all of this is deviant because it's outside of what is considered to be quote unquote normal behavior. And it's not better explained by something else. So again, here's some categories. We have animal type. Again, these are your specifiers. Spiders, insects, dogs. And again, these are just examples. I mean, you could have a phobia of butterflies. You name the animal, it'll go in here. Natural environment type, heights, storms, water, very common. Blood injection injury type. Okay, so with blood injection injury, yeah, this is going to include things like needles, invasive medical procedures, situational, airplanes, elevators, enclosed spaces. I forgot to remember those. Also, okay, so you had blood injection injury, but then you also have fear of injections and transfusions on its own. Then you also have fear of other medical care and fear of injury. And this could be fear of injury within yourself or seeing other people get injured. Either one. Same thing with the other ones up here. And then there's others, like, again, it could be anything. It could be situations that might lead to choking or vomiting. I mean, vomiting in and of itself is a phobia. Seeing vomit's a phobia. Loud sounds, costume characters, whether it's Big Bird or clowns. Again, it could be absolutely anything. Let's see here. In the prevalence, okay, so when it comes to, oh, I do have that. Okay, hold up. All right, so just a couple more slides, and I promise I'll get you guys out of here. Prevalence rates of phobias. Okay, here we go. In the United States, your chance of developing a phobia in the next year, it's about 8 to 12%. So about 1 out of every 10 people could actually be diagnosed with a phobia in the next 12 months. Let's see here. Rates in Europe are pretty similar as well, about 6%. Rates are lower in Asian, African, and Latin American countries. They're down around 2 to 4%. In children, they average approximately 5% across countries, 16% in adolescents, ages 13 to 17 years old in the United States. So we're getting pretty high there, about 1 in 6, 1 in 7. Let's see here. Prevalence estimates are lower in older individuals, again, about 3 to 5%, possibly reflecting diminished severities to subclinical levels. So again, as time goes on, the fear lessens. And I don't think I was phobic as a kid, but I was terrified of tornadoes. And they showed me twisters too early, and I lived in the panhandle of Nebraska. That didn't help. So I was terrified of tornadoes. Even in like the middle of winter, I was terrified of tornadoes. As I got older, though, that started to diminish. And why, I'm not exactly sure. It's not as if I wasn't as exposed to tornadoes as I was when I was young, but and now, honestly, if there's a tornado warning, I'm probably gonna go stand out on my back porch. Let's be honest. If you're Nebraskan out there, you get it. Okay, let's see here. All right, specific phobia, it is associated with suicidal thoughts and attempts based on survey data. It can be associated with transitioning from ideation to attempt. So again, that planning stage to an attempt. For individuals in the community, we're talking like 14 to 24 years of age. A large prospective study over 10 years, okay, so this is longitudinal in Germany, found that 30% of first suicide attempts could be attributable to specific phobia. So again, very young people. There's probably additional anxiety issues that are going on there too, but that's pretty telling. Okay, so then we have agoraphobia. Just jumping all over the place here. And with agoraphobia, this is a specific type of phobia. So with agoraphobia, usually people just think it's like, oh, they just can't go outside. Well, it's a little bit more than that. There's usually a marked fear there is a marked fear or anxiety about 2 or more of the following things. So you at least need 2. You have to be phobic of using public transportation, being in open spaces. So like parking lot, marketplace, bridge, a pasture, the middle of Nebraska. Being in enclosed spaces. So wide open spaces, closed spaces, shops, theaters, elevators, small rooms. Standing in line or being in a crowd. So standing in line at Walmart, being in a crowd at a concert, or being outside of the home alone. That's usually what most people think in regard to agoraphobia. But again, it's more than that. So you have to have at least 2 of the following of those. Then for B, you have to fear or avoid the situation because of thoughts that escape might be difficult, or help isn't available if there's some sort of panic, life symptoms, or other incapacitating or embarrassing symptoms, like you faint or something like that, or you have a panic attack. You have a panic attack, you faint, something like that. And so if you are like, oh, I kind of get this, like in an elevator and that elevator stops and you like, that's what you're worried about. You're worried about it's going to stop. You're not going to be able to escape. Or if you're in like a crowd at a concert, some of those are pretty big. Somebody feel like they might be able to not be able to get out. Or if they're leaving the home, they might feel like, oh my gosh, I know I'm going to pass out. I know I'm going to have a panic attack and I'm not going to be able to take care of myself. There will not be help. C, the agoraphobic situations almost always provoke fear or anxiety. So again, if you're using transportation, you almost always feel this phobic reaction, or you always feel like if you just leave the house. It's not just here and there. These situations are actively avoided, or you have to have somebody that goes along with you, or they're endured with intense fear or anxiety. So in this case, maybe somebody doesn't leave the house, or they have to have a certain person in order to leave the house, or they do it, but they're dealing with tons of anxiety. Same thing with an elevator. Maybe they take the stairs all the time, or they need a certain person to go up and down the elevator with them, or they're on it, but they are sure that it's going to stop and they're not going to be able to escape. And it's out of proportion to the actual danger posed by the situations and to the sociocultural context. So in general, I can't say this for every place in the world. In some places, leaving your house is kind of dangerous. Where most of us probably live, we're very privileged in that we could probably go outside the home and we should not have to worry very much. Again, that's easy telling somebody that's agoraphobic. Standing in line, you shouldn't have to be too anxious necessarily, or in a theater or a pasture, anything like that, or on public transportation. But again, those are pretty low risk situations for danger. But again, somebody who's agoraphobic, that's not the case. And also it has to last for at least 6 months. So this reaction to these situations has to last for at least 6 months or more. And again, it's causing clinically significant distress, high levels of fear, anxiety, shaking, trembling, heart rates high. And then again, not being able to function in society. Maybe you can't get from place to place because you can't use public transportation, or you can't go up an elevator and you got to get to the 100th floor. Like, good luck on the stairs, or you're not leaving your house. And it's not better explained by another mental disorder. But I hope you can see that these phobias are incredibly incapacitating, in that it makes it, I know we kind of joke about phobias, or I'm so phobic of this or that, but it's truly, in general, most of us probably aren't really phobic. Some of us might be, but most are not. And so it's really a serious condition that kind of puts a stop to one's life, truly. The functional consequences of any of these phobias are pretty massive. And when it comes to, oh, I went past it, the prevalence rates. In regard to adolescents and adults, about 1 to 1.7% have agoraphobia. Men are about twice as likely, or women are about twice as likely to have it than men. And then there is a little bit higher of a suicide risk. About approximately 15% of individuals with agoraphobia report suicidal thoughts or behavior. So again, it's not as high as other disorders we're going to talk about here, but it's pretty high. And when we talk about any of these anxiety disorders, most of them are comorbid. So that means that if you're diagnosed with one, you're probably going to be diagnosed with another type of disorder. So like with generalized anxiety disorder, it's very common that somebody might also have major depressive disorder. They might have social anxiety disorder. When it comes to agoraphobia, about 90% of people with agoraphobia have another psychological disorder. And this could be anything from specific phobias, panic disorder, social anxiety disorder, your depressive disorders, PTSD, substance use disorder. So again, they overlap and they go together. So it's not like just one, and again, depending upon what disorder you have, your chances of having another disorder are kind of at a specific rate. Again, almost everybody that has agoraphobia has an additional disorder. So when it comes to phobias, this could be the result of something like direct experience. So some people are phobic of dogs because they were attacked by a dog, or they saw a dog attack somebody they loved, or something of the sort. They saw a dog kill something. That could result in a phobia of dogs. Could be a vicarious experience, seeing someone else encounter a feared object. And yes, so again, with the dog situation, and again, just know I'm the biggest dog lover fan in the world. This is just the example that came to me. We could be talking about a butterfly, we could be talking about a cat, we could be talking about a squirrel, for God's sakes. But vicariously, you experience it through somebody else. So maybe you saw somebody else get attacked by a dog. Or information transmission, learning about a situation or object being dangerous. Oh, you learned that like pit bulls are dangerous. Again, I don't necessarily believe this. I'm just going off of stereotypes for a second. Please don't hate on me for this. But learning that a certain object is dangerous. Again, and if you're told something over and over and over enough, you will start to believe it. Also, preparedness. It's easier for us to acquire phobias of things that would have been useful for our ancestors. So like spiders and snakes. This helps explain my snake issue. It's more likely to fear spiders and snakes than buses, even though the latter are more dangerous. Yeah, a bus is probably going to kill you before a spider or a snake. Or car. Car is going to kill you way before any of those. But are we afraid of cars? No, we're scared of spiders and snakes. But because of our history and ancient, our ancestors, they needed to be scared of spiders and snakes because they could die from them. They didn't have cars and buses and other things that would kill them. So they developed this adaptation to avoid those or to be scared of them. Don't eat them. Don't try to eat the poisonous spider. Don't pet the snake. And so we developed those adaptations as well. Are they as useful today? No. No, they make me look insane in my backyard, running around and screaming, but they're there. Sorry for using the term insane. I look like I something has happened to me. I need a synonym. But nonetheless, that's what our ancestors have prepared us for. They didn't prepare us to be afraid of cars, even though we shouldn't be afraid of cars. So it's easier for us to develop phobias of those things that were naturally adaptive to fear than something like a car. You're going to see more people who are phobic of spiders and snakes than somebody who is phobic of a car. That's what I'm trying to say here. Okay, treatment, you have exposure, you have graduated and structured. This is the type of exposure that I would recommend. I would not recommend flooding. This is literally when you, like, somebody is phobic of snakes, you throw them in a pit of snakes. It does not work. Graduated instructors mean you just go through a progressive hierarchy of situations that are related to your phobia. So with spiders, first maybe you look at a picture of spiders, then you watch a video of spiders. And again, this could take weeks. Then you're maybe in a room with a spider in a cage. Then on the next time you approach the cage, then you touch the spider. Each level may be repeated until the anxiety decreases. And again, this could take years. This doesn't happen over like a month. This could take years. Also, relaxation. It used to be practiced more, now often not a part of empirically supported treatment, but in some situations it can be useful. It depends on the severity of the phobia, truly. Okay, so with that being said, that brings us to the end of that lecture. Again, if you have any questions or concerns, please feel free to reach out to me. Otherwise, I hope you have a great rest of the day and we'll talk to you soon.